Welcome to Roadmap to Resiliency. Hello everyone, I am Abhilas. Welcome to our Club 250 Maths Maker sessions. We are currently in our neurology part. We will be running through a question with you guys to help you on a journey to a 250. So here we have which of the following cranial lobes is most likely to be compromised in this patient. A 55-year-old right-handed woman is brought to the emergency department due to acute onset headache and difficulty with vision. En route to the hospital, she becomes unconscious. Medical history is significant for hypertension. Blood pressure is 150 upon 90 millimeter of mercury and pulse is 90 per minute and regular. CT scan of the head without contrast demonstrates an acute hemorrhage in the left temporal lobe with compression of the anterior medial temporal lobe against the free margin of the tentorium cerebelli. Which of the following cranial nerves is most likely to be compromised in this patient? Abducens nerve, facial nerve, oculomotor nerve, optic nerve, trigeminal nerve, trochlear nerve, or vagus nerve. So let's discuss some of the type of brain herniation first. So here we have epidural hematoma, and this is a subfallopian which is being pushed, and it is compressing the anterior cerebral arteries too. Again, due to the increased pressure, the brain matter is again pushed downward, and it is pushing the oculomotor nerve or cranial nerve free. Okay, and this is called as the uncle or tentorial sort of herniation. If there is herniation of the cerebellum, then that is called as the tonsillar herniation. Now, this question typically is talking about the herniation. Now, here you can see that the patient is having acute onset headache and difficulty with vision. In route to the hospitals, becomes unconscious. Medical history is significant for hypertension and blood pressure is increased. Okay, CT scan demonstrates an acute hemorrhage in the left temporal lobe. Now that left temporal lobe hemorrhage is taking up some space. Okay, and now that is pushing the brain matter. Now here you can see that the patient is having left temporal lobe with compression of the anterior medial temporal lobe against the free margin of the tentorium cerebelli. Now, which of the cranial lobe should be the most likely affecting in this patient? Now, here you can see the cranial vault is formed by the cranial bones and divided into compartments by the dural folds. Because the cranial vault is rigid, there is minimal space for brain expansion if a rapidly enlarging mass or severe generalized edema develops. As a result, portions of the brain may protrude through the openings in the dural folds, often according to the following herniation patterns. Subfalcrine, herniation of the cingulate gyrus under the fox cerebri, uncle, herniation of the medial temporal lobe through the tentorial notch, tonsillar, herniation of the cerebellar tonsils through the foramen magnum. This patient with compression of the anterior medial temporal lobe against the free margin of the tentorium cerebelli has uncal herniation. Now, as uncal herniation progresses, the following changes may occur. Ipsilateral oculomotor nerve compression leads to an ipsilateral fixed and dilated pupil. Paralysis of the oculomotor muscles occurs later and leads to ptosis and down and out position of the ipsilateral eye. Ipsilateral posterior cerebral artery compression leads to contralateral homonymous hemianopsia with macular sparing. Now, this is the typical brainstem ventral view from the first head only. So the thing is that there are four cranial knobs above the pons, four cranial knobs exist the pons, four cranial knobs are in the medulla. Okay. Now, there are four cranial knobs above the pons, four in the pons, and four below the pons, or you can see in the medulla. And there are four cranial knobs in the medial. Okay. Now, every cranial knob, okay, that I can divide 12. Okay, if you can divide 12 by 3, 4, 6, and 12. Now, these four cranial knobs which can divide the number 12 are actually the medial cranial knobs, and other all cranial knobs are the lateral cranial knobs. Now, again, this is the picture of the brain stem. You can see that here is the optic nerve, the oculomotor nerve, the trochlear nerve. The trochlear nerve takes a loop around and again then comes ahead. This is the trigeminal nerve, the thickest nerve, the abducens nerve 6, 7, 8, and we have the cranial nerve 9, cranial nerve 10. This is the cranial nerve 12, and this is the cranial nerve and 11. Now, this is the histological picture of the midbrain. Now, You can find some NBME pictures circulating in, and also you can, when you do the NBMEs, then you can find the NBME pictures. Now that picture is closely resemble to these sort of pictures, and you have to determine the pathology from these sort of histological pictures. Sometimes these pictures may be the only hint that may tell you where is the pathology or what is the answer. So first of all, you have to know from where this histoslide have been taken and how you can actually understand where this histological slide is taken from. So here you can see this is the midbrain. Okay, so we have the superior colliculus, and this is the cerebral aqueduct of Sylvius. Okay, this is the one of the differentiating factors of the midbrain. This is the cranial of three nucleus in the between. This is the medial lemniscus. This is the cranial of three fibers coming out, and here we have the red nucleus, the substantia nigra. Okay, and this is the cross cerebri. Okay, now you can differentiate the midbrain from even from the diagnosis of exclusion, or from the cerebral aqueduct, or the oculomotor, or the cranial of three nucleus. And whenever there is pathology in these parts, then the specific symptoms will appear. Now this is the Pons. Now Pons is very easy to understand. This is the typical shape of the Pons. I call this a kidney shaped. Now this is the hilum of the kidney, and these are the ureters, or the renal arteries and vein protruding out. Okay, so this is how I remember. But you can actually understand or recognize it just by seeing the fourth ventricle. If the fourth ventricle is shown here, then that means that this figure is of Pons. Now in Pons, you have the medial longitudinal fasciculus. Okay, you have the medial lemniscus, you have the cranial five nucleus, and you have the corticospinal and corticobulbar tracts. Now medulla is the easiest to understand, because as soon as you see this inferior olivary nucleus, the spaghetti-like bodies, then you can easily understand that this is the medulla. And this is the cranial tubular nucleus. This is the dorsal motor nucleus. This is the nucleus tractus solitarius. This is the cranial of 10. This is the medial lemniscus, inferior olivary nucleus, nucleus ambiguus, medial longitudinal fasciculus. Now, whenever there is lesion in this part, okay, sometimes the half of the medulla is involved, then that may lead to some of the very harsh symptoms. So the first thing that I only want to convey from this video is how to understand the histology. So the midbrain controls the involuntary eye movement and reflexes related to the visual and audio information. So if there is a lesion of the midbrain, then there must be some symptoms of the eye. Okay, we have seen the superior colliculus involvement. The pons release the masses from the cortex to the cerebellum and responsible for the facial sensitivity, and plays a major role in the sleep behavior. Okay, the medulla oblongata regulates the breathing, heart rate, digestion, and sleeping, and plays a role in regulating the muscle tone and movement. Responsible for initiating reflexes such as vomiting, swallowing, gagging, coughing, sneezing, and hiccuping all comes from the medulla oblongata. So when these typical functions are affected, and then on top of that we are giving a histology slide, then you can easily crack out the question. Now, before finishing, I do want to discuss this one important concept that is very frequently tested in examination. Now, there are three primary vesicles for prosencephalon, mesencephalon, and rhombencephalon. The prosencephalon develops into telencephalon and dilencephalon, mesencephalon, metencephalon, and myelencephalon again. Now, this telencephalon forms the cerebral hemisphere and basal ganglia. The diencephalon forms the thalamus, hypothalamus, and retina. Mesencephalon forms the midbrain. Okay, metencephalon forms the pons, and myelencephalon forms the medulla. The development of the brainstem structures are very important, and they specifically ask you about mesencephalon, myelencephalon, and metencephalon. Okay, you just remember the sequence, and you are good to go. Thank you for watching. Keep studying.